Assalamualaikum everyone.
तो शॉर्ट्स कर दीजिए।
हाँ ये कर लो बस ठीक है चलो फुल स्क्रीन करो चलो
Preterm labor is spontaneous onset of labor before 37 completed weeks of gestation. What are the objectives? Identification of risk factors, identifications of patients who may benefit from antenatal progesterone, evaluation and management of preterm labor and pre-labor rupture of membranes, reduce adverse neonatal outcomes as well as maternal morbidity. Types of preterm births. WHO defines preterm birth into 3 categories: moderate to late preterm birth from 32 weeks to 36 plus 6 weeks of gestation, very preterm birth from 28 plus 0 to 31 plus 6 weeks of gestation, and extreme preterm birth from 24 to 27 plus 6 weeks of gestation. The incidence of the preterm birth overall is 11.4%. Spontaneous preterm birth with intact membrane is 45%, and PreProm is 25%, and electively induced is 30%. Now the risk factors for preterm birth. History of preterm delivery. If someone has got a history of preterm delivery, then the risk is 20%, and multiple gestation. If someone is having a multiple gestation and the previous was a singleton preterm delivery, then the risk is 67%. But if someone had previous preterm term delivery, then the risk reduces to 21%. Short cervical length or transvaginal ultrasound that is less than 25 millimeters at 18 onwards.
Ma'am, kindly show the slides.
You can't see the slides?
No, you can do.
No,
you?
sir.
Slides not visible. Girls, can you see the slides?
Yes, sir.
Yes?
यस नजर आ रही है यस मैम अब भी विजिबल है
Inter-pregnancy interval of less
ऐसे ही रहने दो। चलो
Inter-pregnancy interval of less than 6 months, tobacco use, infections like bacterial vaginosis, bacteriuria, which could be asymptomatic, urinary tract infections. Preterm labor with intact membranes. With a short
कोई बात नहीं यार देख लेना क्यों हो गया कुछ खुद भी याद करके आना ना सारी
उसको लेफ्ट पे ले जाओ बॉक्स को जहाँ पे 1 2 3 4 5 6 स्लाइडें हैं ना हाँ इसको लंबा भी कर दो
Sure.
Considerations for the prophylactic vaginal progesterone or prophylactic cervical circulage. You will consider for the prophylactic vaginal progesterone if there is a history of spontaneous preterm birth that is up to 34 weeks or mid-trimester loss from 16 weeks of pregnancy onwards. And if the transvaginal ultrasound carried between 16 and 24 weeks showing cervical length of 25 mm or less. And we will consider the prophylactic cervical circulage if the cervical length is 25 mm or less between 16 and 24 weeks. And if there is a history of preterm pre-labor rupture of membranes in a previous pregnancy, or there is a history of cervical trauma. If you suspect someone with PreProm, offer a speculum examination. If pooling of amniotic fluid is observed, no more diagnostic tests, just care consistent with PreProm is required. If no fluid seen, perform insulin-like growth factor binding protein 1 test or placental alpha microglobulin 1 test, which is also called as ablation. If tests are positive.
So I have a question for you. This insulin-like growth factor binding protein, is this test available in Pakistan?
Maybe Agha Khan lipstick test.
So अगर Agha Khan में available है तो is it available in Lahore? So we need to check from the Agha Khan laboratories, and this is your job. You are going to check from the Agha Khan laboratories whether this test facility is available. If it is available, how much does it cost? इस किस्म की चीज अगर आपको पता हो and you are sitting in a private facility, you could actually do it in a couple of patients so that you are able to talk from your experience. या placental alpha microglobulin. मैं कहता हूँ ये तो शायद ना हो, लेकिन placenta मेरा ख्याल गया कि insulin like growth factor binding protein might be different. Okay, so check it out.
But if tests are positive, we don't have to start the prophylactic antibiotics. Rather, we have to reevaluate the clinical condition of the patient, and if it goes further, that we have to start the treatment.
So my question is, why do you not need to give prophylactic antibiotic if test is negative?
मैम prophylactic क्योंकि antibiotics पे जो research हुई है उसका ऐसा कोई benefit नहीं है risk reduction.
ये वजह नहीं, वजह कोई और है. Why are you not giving prophylactic antibiotic if insulin-like growth factor binding protein is negative? क्योंकि लीकिंग ही
नहीं है ना क्योंकि diagnosis आपका नहीं होगा.
मैंने तुम्हारा जो डायग्नोसिस किया वो ये किया कि तुमने लिखा हुआ है, तुम्हारा कॉन्सेप्ट डेवलप नहीं है. Because there is no amniotic fluid that is seen, and you are doing the test if you can't see the amniotic fluid. तो पहले तो आपको amniotic fluid ही नहीं मिला, इसका मतलब है diagnosis is questionable. Then, in order to reassess, you did this insulin-like growth factor binding protein test. When you did the insulin-like growth factor binding protein test, and it turns out to be negative as well, then why would you give prophylactic antibiotic? Because PreProm is not confirmed. It is just the history of the patient. That is your logic. अगर वैसे नहीं है उसका फिर पूर्ण रोल तो फिर देते क्यों, तो बंद दिया करो. रोल तो है, ऐसी तो बात नहीं है, कोई रोल नहीं. चलो तो अभी आगे एंटीबायोटिक्स. Why are you giving antibiotic if you think there is no role?
No, exactly. Antenatal prophylactic antibiotics for PreProm. Oral erythromycin 250 mg 4 times a day for a maximum of 10 days or until women is an established labor, whichever is sooner. If contraindications to macrolide group, then we can give oral penicillins.
What is macrolide group?
Okay, azithromycin.
ये macrolide group है, इसको नहीं पता था तुमको?
नहीं मैम मुझे पता है.
अच्छा, तो कॉमन नहीं डाला बीच में, लग रहा है कि
अच्छा
macrolide oral penicillin एक ही जाता है ना? तो फरूक की कमी का एहसास ना हो.
जी मैं बिल्कुल सही कह रही हूँ.
उन्होंने पकड़ लेना था तुम्हें.
Identification of infection in women with PreProm. Clinical assessment and tests which are required are the C-reactive proteins, white blood cell count, measurement of fetal heart rate using cardiotocography, and these should be serial and in correlation with the clinical condition of the patient. Assessing the likelihood of preterm delivery. These are the two diagnostic tests. The first one should be the cervical length measurement, and the next one should be the fetal fibronectin. If the woman is 30 plus weeks and you suspect her to be in a preterm delivery, then cervical length measurement is performed through TBS. And if it is less than 50, if it is either 15 millimeters or less than, then she is an established preterm labor. Then you have to give the care consistent with it. And if cervical length measurement is not available or acceptable, then you have to perform the test fetal fibronectin, which we have to see its concentration. That is, if it is more than 50 nanograms per ml, then she is probably she is an established labor.
So what is fetal fibronectin?
Fetal fibronectin test हम करते हैं cervical vagina fluid से swab लेते हैं.
So what are you testing?
वो है ना glycoprotein. मैम सबसे ज्यादा तो ये होता है amniotic fluid. और दूसरा ये वैसे हो सकता है सामने fluid में.
So basically it's a binding protein which is present between the fetal membranes and the endometrial line. And when the patient goes into preterm labor, fetal fibronectin is released actually. When fetal fibronectin is released, its level becomes high. And that is what you're looking for. Again, my question is it available? Pakistan maybe. मैंने तो नहीं सुना कि fetal fibronectin यहाँ होती हो, but it can actually be done as a spot test as well. चलो, आगे चलो.
Management of preterm labor. Antenatal corticosteroids covered if required, tocolysis, transfer to higher level of care if required, and GBS prophylaxis.
What is GBS?
Group B streptococcus, not gay.
Isn't it too late to give a group B streptococcus prophylaxis? क्या होता है GBS prophylaxis? What do you give actually?
मैम ये हम देते हैं क्योंकि अगर हम ये prophylaxis नहीं देते तो फिर जो early onset ना severe early onset infection हो जाता है the neonates due to group B streptococcus.
So what do you give for this group B?
मैम इसके लिए हम देते हैं penicillins 3 gram dosage दी हुई है intravenous.
3 gram.
जी मैम 3 gram. आप स्टेट में देते हो 3 gram और उसके बाद 1.5 देते हो 4 early until
Which penicillin? करते हैं कौन सी
नहीं मैं इसका गंजाल कंसील
ऐसे नहीं देख के बताना चल आगे
Antenatal corticosteroid treatment can be given from 24 to 34 weeks. It is effective in intact and ruptured membranes. There are two kinds of steroids that could be given. The betamethasone, the dose is 12 mg intramuscular every 24 hours, 2 doses. Dexamethasone 6 mg intramuscular every 12 hours, 4 doses. A single repeat course of steroid is indicated if there is continued risk of preterm delivery and estimated gestational age if it is less than 33 weeks. And it has been more than 14 days from the last steroid administration. Tocolysis. Tocolysis is used to delay delivery up to 48 hours. In some books, it is written even up to 7 days. Actually, to give antenatal corticosteroids, devious prophylaxis if required, magnesium infusion for neuroprotection, and transfer to the higher level of care if needed. Drugs for tocolysis are nifedipine, terbutaline, indomethacin, and atosiban, but which is again not available here. Nifedipine is a calcium channel blocker, and there's a decreased likelihood of delivery within 48 hours, and there's an improved neonatal outcome. Contraindications to nifedipine are maternal hypotension. The loading dose is 30 milligram, then 10 mg orally every 4 to 6 hours can be given up to 120 mg. Terbutaline is beta-sympathomimetic drug. Decreased likelihood of delivery within 48 hours is seen. Useful in patients having uterine tachycystole due to rapid onset of action. 0.5 mg every 20 to 30 minutes for up to 3 doses can be given subcutaneously. Contraindications to terbutaline are heart diseases, poor controlled diabetes, thyrotoxicosis, and it should be avoided in large volume conditions like polyhydramnias and multiple pregnancies.
वो आ गया 3 gram benzyl penicillin stat, then 1.5 gram 4 hourly pill label.
Benzyl penicillin.
मैं benzyl penicillin इसमें 10 टीचर्स में इसके लिए नहीं लिया, वो किसी और कंडीशन के लिए था।
अभी चेक हो रहा है लेकिन ये वहां से आया है क्योंकि ये नहीं हो सकता कि किसी किताब में खाली पेनिसिलिन लिखा हो। ये मैं तुम्हारी बात मानने को तैयार हूं, मैं तुम्हारी बेंजाइल पेनिसिलिन मान लूं कि नहीं है, लेकिन ये नहीं हो सकता कि टाइप ऑफ पेनिसिलिन बुक के अंदर ना डिफाइन हो। ऐसा नहीं हो सकता। हां
वो मैंने 10 टीचर्स पढ़े
तो 10 टीचर्स में अच्छी होती है ना 10 टीचर्स में भी चलो।
Endomethacin. Endomethacin is an NSAID. It is effective in increasing estimated gestational age and delivery by an average of 3.5 weeks. Indicated when preterm labor is before 32 weeks. Preterm labor is associated with polyhydramnias. Fetal adverse effects are closure of the ductus arteriosus, actually the premature closure of the ductus arteriosus and oligohydramnias. 50 milligram oral or rectal loading dose and 25 to 50 mg orally every 4 to 6 hours. Total of we can give 200 mg in 24 hours.
So my question is it currently being used?
No, ma'am.
Because of
Ma'am, we get a closure of ductus arteriosus.
उसके साइड इफेक्ट्स भी जैसे इंडोमेथिसिन इवन टेबुटलिन ना होने के बराबर यूज होती है। ज्यादातर इस सब जो स्टैंडर्ड ऑफ केयर है फॉर प्रीटर्म लेबर दैट इज डिफरेंट।
Magnesium sulfate. Magnesium sulfate decreases cerebral palsy when given immediately prior to and up through the time of delivery. Indicated for 24 to 33.
जी मैडम। Indicated penicillin G का क्या है? Intrapartum antibiotic prophylaxis against group B streptococcus.
पेनिसिलिन जी
Penicillin G 5 million units intravenous administered as a loading dose.
5 million units
हाँ जी units intravenous. Followed by 2.5 to 3 million units every 4 hours during labor until delivery. Ampicillin is a reasonable alternative to penicillin G. Penicillin G is unavailable. But ampicillin 2 gram IV loading dose followed by 1 gram IV every 4 hours.
that is easier, isn't it?
And that's easy, but the first choice is penicillin G.
Otherwise, ampicillin 2 gram.
Loading dose followed by 1 gram every 4 hours.
Magnesium sulfate is indicated for 24 to 32 weeks. Maternal side effects associated are flushing, headache, diplopia, pulmonary edema, cardiac or respiratory arrest.
So अगर तुम ये side effects मुझे बताओगी तो मैं तुम्हें कहूँगी कि दें कि ना दें।
मैम देना चाहिए with monitoring.
तुमने तो side effects बता दिए। तुमने आज तक तुम लोग अपने लेबर रूम में दे रहे हो कितने पेशेंट्स को तुम उसको monitor करते हो for cardiac arrest and pulmonary edema and diplopia, flushing and headache. So what do you
हेडेक के लिए देखते हैं और यूरिनरी आउटपुट के लिए
हम तो सिर्फ यूरिनरी आउटपुट देखते हैं, वो क्यों देखते हैं?
अब रिड्यूस होता है ना सिर्फ यूरिनरी आउटपुट।
तो हम बेसिकली इसलिए देखते हैं कि कोई उसका साइड इफेक्ट तो नहीं हो रहा. But we don't look for these. So when you are presenting a presentation and you are giving these kind of side effects, तो उनका फिर incidence भी लेके आया करो कि ये common है, unusual है, ये rare है. Because if it is a rare side effect, then this drug is acceptable. But otherwise, if you tell me that it is going to cause pulmonary edema and cardiac and respiratory arrest, I will never use it. So you have to, तुम इसको promote कर रही हो, इसके खिलाफ बता दो. ये तुम्हारा फैसला होना चाहिए. So if you think that it should be given, then the side effects have to be catered for. इसका जवाब चाहिए. ठीक है?
Dosage. Loading dose of 4 gram over 20 to 30 minutes, then 1 gram per hour maintenance continued for 24 hours with monitoring of urine output. Loading, second alternative is loading dose of 6 gram over 20 to 30 minutes, then 2 gram per hour continued for 12 hours.
I think we are used to the 4 gram dose.
4 gram.
And that is what we do in HMC as well. So I would think that the loading dose of 4 gram to be given in 1 hour or to be given in half an hour and then 1 gram per hour for 24 hours. I think this should be okay for us because we are used to this and this is what is generally accepted. Chalo, aage.
Delayed cord clamping. The significance of
कितने लोग हैं जो delayed cord clamping करते हैं और जो भाग के clamp लगा देते हैं? कितने हैं वो लोग? सारे. So, हाँ सर मैं और डॉक्टर फारूक. तो तुम लोगों को याद रखना चाहिए कि there is a reason for delayed cord clamping. मैं बताऊं?
It decreases intraventricular hemorrhage and need for transfusion of the fetus. After delivery, hold the infant at or below the level of the placenta for 1 to 3 minutes prior to clamping and cutting the umbilical cord. If the infant is depressed or mother is actively bleeding, then clamp and cut ASAP.
Obviously, if the baby is not healthy, then you're not going to wait for 3 minutes and let the baby go. So this you do only for a healthy.
जी मैम मैम ये भी लिखा होता है कि अगर प्रीटर्म बेबी है बट हेल्दी है तो आप फिर 30 सेकंड्स के लिए उसको क्लैंप करें मिल्किंग करके 30 सेकंड्स का फिर आप उसको कट करें
Preterm baby को 1 minute काम करोगे क्या ये?
जी मैम इस पे ये लिखा था कि नाइस गाइडेंस का कि 30 सेकंड्स तक करना चाहिए.
वैसे भी आप कौन सा 3 मिनट कर रहे हो? सेंटर क्या है? चलो
kindly speak loud.
Speak loudly. कौन मैं ये? वैसे loud. Both? Okay. Speak loudly.
Delivery route. Gestational age does not dictate delivery route. Premature fetuses have a higher rate of malpresentation and loss of tolerance of labor stresses, resulting in a high rate of cesarean delivery. Vacuum delivery is contraindicated under 34 weeks due to risk of intracranial hemorrhage. Forceps delivery or episiotomy does not improve or worsen the fetal outcomes.
So my question with this slide is that are you saying that preterm baby should be delivered by cesarean section? What are you saying?
हम ये नहीं कह रहे लेकिन वो कह रहे हैं कि ज्यादातर अगर सिजेरियन सेक्शंस होते हैं वो उसकी रीजन बताइए ड्यू टू रेट ऑफ मैलप्रेजेंटेशन है अगर बीच है अगर लीगो है तो फिर तो ऑब्वियसली डिसाइड करेंगे बट अदरवाइज कोई प्रायोरिटी नहीं
So
है.
basically you are saying that there is no contraindication to vaginal delivery in preterm babies. But in extreme preterm babies, actually you haven't mentioned that, but in extreme preterm babies, operative delivery might be helpful, especially if there are other comorbid factors. Okay? Chalo.
GBS prophylaxis. Women who should receive intrapartum antimicrobial prophylaxis include GBS bacteriuria in any concentration during current pregnancy, previous birth of an infant with GBS disease, positive GBS vaginal rectal screening culture, unknown GBS status at the onset of labor, and GBS risk factors, that is rupture of membranes for more than 18 hours, temperature of 100.4 degree Fahrenheit, and if estimated gestational age is less than 37 weeks.
The conclusion. Chalo. So can we start from the first slide? Can you give this to me? Let's see. So anybody who wants to make any comment, please.
मेरा वो टर्मिनली वाला पार्ट रह गया था तब मैं सर्च करके वो बता दिया.
The butyl
और
का तो
जैसे मैडम के आपने कहा था ये यूज
इंडोमेथासिन का तो मैंने बेसिकली ये कहा था कि इंडोमेथासिन and butyl are not the drugs of choice currently. Let's start from the beginning because I would just like to highlight a couple of factors. I think the most important thing about preterm labor or premature rupture of membranes that you need to remember is that prematurity increases the morbidity and mortality of the baby. And about 30% of the premature of the 30% of the neonatal mortality is because of this premature labor. So this is a very important issue for us, and premature labor is more common in countries which are poor, which have got poor resources, and I think risk factors were not discussed. हालांकि तुमने introduction में कहा था, जो important चीज है that who are the people who are at risk of preterm labor. The women who are at risk of preterm labor include those women who are trying to become pregnant less than 18 months. So in women in whom the birth interval is less than 18 months are more likely to deliver premature babies. Around 20% incidence hai if the birth interval is only 1 year. So 20% probability of preterm labor. Usual probability of preterm labor is around 12%. So then there are other factors like environmental factors, like climatic factors, like use of tobacco, alcohol, and hard drugs. All of these increase the chances of preterm labor. Then, as she told us in the presentation, that 30% of preterm labors are iatrogenic. तो हम जो बार बार इंडक्शन ऑफ लेबर करते हैं फॉर रैंडम इंडिकेशंस, दो चीजें हम सही नहीं करते. डायबिटीज है उसको इंड्यूस कर दो, प्रीक्लेम्स है उसको इंड्यूस कर दो, फुल टर्म हो गई है इसको इंड्यूस कर दो, बच्चा बड़ा लग रहा है इसको इंड्यूस कर दो. These are all wrong indications for induction of labor, and that is why I would like to come to the quality of antenatal care. So when any woman presents to you, तुम लोगों ने कभी एंटीनेटल कार्ड देखे हैं जिसमें पहले दिन से लिखा होता है अनश्योर ऑफ डेट्स, और जब वो पेशेंट जनवरी में आई थी वो तब भी अनश्योर ऑफ डेट्स थी, और अब जुलाई आ गया वो अभी भी अनश्योर ऑफ डेट्स है. What is wrong with that card? What is wrong with the card is that they have not and never tried to calculate the expected date of delivery. So on the first visit, I can understand somebody coming to me and saying that I don't know my dates. But if that patient comes to me again, I should have calculated the due date and then I should be working on that date. And one of the reasons for preterm labor is women presenting to you saying that they have 9 months amenorrhea and they are multiparous. And you don't know the duration of pregnancy and you assume or presume that it is post-date annuities. That is why there is a 30% iatrogenic cause of preterm labor. So मैं अगर आपको कोई आज एक मैसेज देना चाहूँ तो ये होगा कि induction of labor ना करें unless you are absolutely sure of the indication. Even gestational diabetes mellitus, which is well controlled, there is no indication of induction of labor. उसको labor में जाने दो. You can wait till 41 weeks in women who are well controlled diabetics. Even in preeclampsia, 37-38 weeks पे induction की जरूरत नहीं है. Unless there is evidence of IUGR and there is proteinuria, then you can think of induction of labor. वरना otherwise हर एक को induce करने की जरूरत है. दूसरी बात जो environmental factors हैं, जो डाइट के फैक्टर्स हैं, जैसे कि मैंने बताया कि ये अल्कोहल, ड्रग्स एंड टोबैको, जिसको हम प्रिज्यूम करते हैं that our women are not into it, we should ask the history. The third thing is that the short interpregnancy interval leads to preterm labor, and it is our responsibility to ensure birth spacing of 3 years in every woman who is young and of reproductive age. जाहिर है अगर कोई औरत 36 साल की है तो तुम उसे ये तो नहीं ना कहोगे कि तुम 3 साल तक birth space करो. So the women who have got previous history of preterm labor, or who have got a smaller birth interval, or who have got multi-fetal pregnancy, or over-distended uterus are all likely to go into preterm labor. Then conditions like abruption, placenta previa also predispose to preterm labor. Second trimester abortion also predisposes to preterm labor. So if you look at the list, and one important cause which I haven't mentioned and they have mentioned, जो आपने कहा था कि GBS, एक recurrent vaginal infections and recurrent UTI. And you see a lot of women coming to you in pregnancy who are not taking enough water, who are not getting vaginal infection in pregnancy treated, and some women actually have got serious vaginal infections in pregnancy and we don't treat them effectively. So if we don't treat them effectively, these women are also likely to go into preterm labor. So, जी.
Uterine congenital anomalies है, इसके ऊपर भी comment है कि वो भी
जी,
4%
uterine congenital anomalies can also increase the chance of preterm labor, but unfortunately, about uterine anomalies, you can't do much about it, right? But you can do a lot about so many other things. So look at the causes of premature labor. Always try to assess what was the cause of premature labor in your particular patient, and do a risk factor assessment on the first antenatal visit. So you can identify that is there a possibility of this woman going into premature labor? If there is a possibility, then you have got choices like McDonald's stitch or cervical cerclage, like the radiant pessary, like the use of progesterone. So all of these things and infection prophylaxis or infection treatment. So all these things can actually prevent preterm labor. So when you talk about preterm labor, you should first talk about risk factor identification, calculation of estimated calculation of date of delivery, then estimating the risk factors for preterm labor, given the preterm labor prophylaxis if it is required. Then if the woman actually goes into preterm labor, then trying to identify. So there are two kinds of preterm labor. एक वो होगा जिसमें आप लेबर को रोकने की कोशिश करोगे, एक वो होगा जिसमें आप कुछ नहीं करोगे. So a patient with recurrent bleeding in pregnancy goes into preterm labor. You will probably not try to stop it, right? A woman who has got an IUGR goes into preterm labor, you will not stop it. But women who have got a normal pregnancy and they go into preterm labor, you are going to try to arrest that labor and monitor. So arrest करने के लिए labor basically जो है हमें जब labor arrest की बात करते हैं तो जो आपने तीन drug choices बताई थी terbutaline, nifedipine and indomethacin. So basically at this point in time the most favored is nifedipine, which is given in a loading dose of 30 books में कहती है 30 milligram loading dose and then 10 milligram every 4 to 6 hours till a maximum of 120 milligrams, or you stop if there is tachycardia because it can cause tachycardia. So once the labor is arrested, then you keep on monitoring your patient feature for infection and look at other things and go on forward. But the important thing to remember is that if the woman goes into labor before 24 weeks of pregnancy or the cervix starts shortening, then you have to keep an eye and you might give progesterone, the cervical stitch or the irradiant pessary. ठीक है, क्योंकि लोग कहते हैं कि जो evidence है randomized control trials का that shows that they are all equally effective. So then you come to women, I think, which is important to talk about, who present to you with premature rupture of membranes, because prematurity, as I told you before, it is a significant problem because a high neonatal mortality is associated with premature rupture of membranes. So the first thing is making a diagnosis, and the second thing is what to do about it. So most of the people think that if the woman has got premature rupture of membranes, it is important to deliver her 48 to 72 hours after rupture of membrane. It is not necessary. If you can monitor the patient in terms of her leukocyte count, in terms of the C-reactive protein, and in terms of frequent ultrasound for cervical length and the amount of lighter, then you can wait for with rupture of membranes, putting the woman on antibiotic, which is mostly erythromycin. But I was reading that you can give a combination of cephalosporin plus erythromycin as well, or you can give them individually. So RCOG says erythromycin is the first choice, but you can give a combination too. जैसे कि हम लोग तुम लोग नेटवर्क में देखते हो कई दफा रोसिफिन और erythromycin दोनों दे रहे हैं. So you can do that and give dexamethasone. If dexamethasone has been given 2 weeks before and the woman is still not 34 weeks, then you can still repeat the dexamethasone, or you can give dexamethasone up till 37 weeks of pregnancy. So there are various recommendations. In addition to that, magnesium sulfate if the delivery is being done before 34 weeks. So 32 weeks that magnesium sulfate recommended have with monitoring, but it should be given preferably in those in whom delivery is imminent. Generally, उनमें नहीं देते जिनमें भी आप कुछ भी नहीं कर रहे हो. So this is the management. Antibiotic generally not recommended for more than 10 days, but if the leaking decreases in amount, if there is no sign of congenital and you are monitoring the pulse and temperature and the color of lighter, if there is nothing like that, there is no cord prolapse and there is no other thing with rupture of membrane, then actually you can continue with conservative management till the time either the maturity is achieved or you have adequate facility for delivery. Or please in utero transfer की बात जरूर करो, because a premature baby should not be born in every hospital. A premature baby should be born in a hospital which has got adequate facilities for management of preterm babies. That might be actually a private hospital or a good public sector hospital, it does not matter. लेकिन premature बच्चा हर जगह नहीं होना चाहिए, because after delivery of the baby, shifting the baby to a better neonatal facility is more difficult and more traumatic for the baby and results in more morbidity than shifting the mother. So send the mother to a hospital where there is adequate facility. You would do a great justice. So इसको कहते हैं in utero transfer, and you must comment on in utero transfer of the babies. ये बात हो गई. फिर उसके बाद once the baby has been born, your responsibility is not over, because there are a couple of very important things, and as she mentioned delayed cord clamping, I think I would like you to mention a couple of things, that what are the risk factors for death in preterm babies. So the risk factors are not maintaining the room temperature, early cord clamping आपका risk increase कर देता है, and not providing breast milk to the baby. So in premature babies, if we want them to live longer and we want them to survive this prematurity, then we have to ensure delayed cord clamping, early breastfeeding, early drying of the baby, adequate temperature maintenance, skin-to-skin contact with mother, and infection prevention, because these are the most common causes of death. बच्चे की infection prevention के लिए दो बातें हैं: applying chlorhexidine gel on the cord of the baby and handling the baby only by selected people who have got clean hands. चाहे वो hand wash से करें, चाहे वो soap and water से करें, but only with clean hands and no evidence of infection themselves. So ये infection prevention के लिए है, temperature maintenance के लिए, you're drying the baby early, keeping the baby in a garment which is worn over the chest of the mother in close contact with the chest, so the maternal chest actually becomes the incubator for the baby, and the baby immediately takes up the temperature of the mother. And also trying to ensure that the room temperature is also, I think it is around 26 or 28 degrees, which is an appropriate temperature for the baby to survive. And prevention of hypoglycemia can be done by early breastfeeding. So if the mother is breastfeeding, keeping the baby close to the maintaining the skin-to-skin contact, kangaroo mother care. और kangaroo mother care का ये है कि आप उस बाइंडर के अंदर बेबी को उस वक्त तक रखें, बेबी या तो खुद
ये इलेक्टिव फाइल अंदर ही है क्या? हाँ, तो ये इलेक्टिव की प्राइमरी ब्रीच थी, और जो है ना वो प्राइमरी ब्रीच पे सेक्शन हुआ है 7 बजे सैफा फ्लैजे रूटीन का फॉलो कीजिए.
Okay, so either till the time that the baby moves out of your binder, or the baby moves out themselves, or till the time an adequate weight is achieved. So अगर वो बच्चा 1.5 किलोग्राम का हुआ तो आप उसके अंदर वो चेस्ट के अंदर रखने से the binder, the baby increases weight को monitor कर रहे होते हैं इसके अंदर, और बच्चे को temperature को भी monitor करते हैं, and the mother is told of the signs of danger signs for the baby. Danger signs बच्चे के क्या है? Not able to take the feed, rising temperature, listlessness, and not wanting to suck. So ये सारी चीजें जो है and टिकटनिया यानी रेस्पिरेटरी रेट का इंक्रीज हो जाना, ये बच्चे के डेंजर साइंस हैं जो मदर को बताते हैं. शुरू में ये मदर्स को हॉस्पिटल में रखते हैं, but then with counseling and management tips they can be sent home. So इसको कहते हैं kangaroo mother care. Kangaroo mother care is a low cost intervention to save the lives of the preterm babies. Kangaroo mother care तुम लोगों को जरूर आना चाहिए. I think I will stop over here and I will let you ask questions. किसी ने कहा कि next class कोविड पे कर ले, so no जरा ऊपर जाएंगे, मैंने पढ़ा था
Research writing
लिखा हुआ है कोविड, उससे ऊपर वाला बड़ा कर.
So let's talk about COVID first and then research writing. Yeah, request for please arrange a class on research, article writing, and COVID in pregnancy. So let's do COVID first, and then we will do research and article writing. Okay? COVID in pregnancy में वैसे कोई बहुत लंबी चौड़ी नहीं है. I would rather कि तुम लोग डेंगी कर दो. डेंगी is more difficult to manage. लेकिन ठीक है, COVID कर दो. जी जनाब, any questions?
वो बताएं कि टर्बिटुलिन और
हाँ, उसका ये बता रही थी कि जो टर्बिटुलिन है उसको I don't know why it has gone out, but I think it was associated with a lot of tachycardia or endometriosis जो है that causes premature closure of the ductus arteriosus, so that is why it is not here.
So we don't use them at all.
So we don't use them. Nowadays they are not in practice. Europe में वैसे ही और US वगैरह में pitocin आ गया. Pitocin is a very good agent to arrest labor. And the second thing is that in countries which are in higher income countries, I would say, who have got better neonatal facilities, they only want to arrest labor for a couple of days. So their issue is actually not much because they are going to give the drugs and ship the baby to a facility where a proper facility is available and deliver the baby. It's just that gestation till which magnesium sulfate is offered is 32 weeks. If you correct the talks course again, online कर देते हैं. Okay, I will do it online. It's
Madam, nifedipine is not readily available. So then what we have to do? Then we have to shift to terbutaline.
अगर nifedipine available नहीं है और आप terbutaline यूज करना चाहते हैं simultaneously आप इन दोनों को mix कर रहे हो. Magnesium sulfate का रोल फर्क है, nifedipine का फर्क है. So if you want to arrest labor, you can give nifedipine, and if you think that delivery is imminent, you give magnesium sulfate.
32 to 34 तक आपने कहा था कि दे सकते हैं.
Basically 34 is the cutoff line to 32 तक. 34 वाले बच्चों को कहते हैं कि magnesium sulfate की जरूरत नहीं है. कराची गर्ल्स कितनी हो बताओ? कराची आके करा दूं या ऑनलाइन करा दूं?
मैडम ऑनलाइन करवा दें.
मैडम
Okay,
मैडम
let's okay, next week is तुम्हारा एग्जाम है ना 4th of July.
मैडम की डोज है वो न्यूरो प्रोटेक्शन के लिए वही है जो हम कैंसर के देनी है.
नहीं समझ आई, दोबारा बोलो.
मैडम जो मैग्नीशियम सल्फेट की डोज है न्यूरो प्रोटेक्शन के लिए जो कैंसर के देनी है.
कपड़ा मोकलना ना वो मोकला से वो जासूस करने
कौन सा कपड़ा
मैग्नीशियम सल्फेट पर न्यूरो प्रोटेक्शन बता दें.
1st July. एक दिन में आपको बताते हैं, we will post on the group portal. Okay, we'll do it online. क्या हम 8 से 2 तक ऑनलाइन चला सकते हैं? We will do one station, then go to the next station. We will demonstrate it for them, so you girls can actually become the. चलो चलो
Can you show slide of
हेलो अस्सलाम वालेकुम. प्लीज शुरू स्टार्ट की 2-4 स्लाइड शो कर दें.
देखो nifedipine की डोज आ रही है, जिसको nifedipine की डोज चाहिए थी. Terbutaline का एक्चुअली बड़ा सिंपल है, 3 डोजेस देनी है, 0.75 मिलीग्राम से ऊपर नहीं जाता. And you have to make sure that patient diabetic, cardiac, medical conditions now. So if there is any medical condition, terbutaline is contraindicated. 3 doses, 0.25 milligram each every half an hour subcutaneously. और क्या है? आप भाई अनम्यूट करते हैं इनको. Then about the tocolysis in cardiac patient, nifedipine. But you have to remember that nifedipine is going to cause tachycardia in cardiac patient. So and that also causes hypotension. So you have to make sure that your patient actually should be a stable cardiac patient. Otherwise, if the patient is not stable herself and you give her drugs which cause her tachycardia, it might cause a problem. So actually, you might give the loading dose of magnesium sulfate for that patient. क्योंकि अगर तुम याद करो तो magnesium sulfate भी tocolytic agent है. So अगर मैं हूँ और मेरी patient cardiac disease है और वो unstable patient है, she has already got tachycardia or there is risk of cardiac failure, तो मैं उस patient को magnesium sulfate मैं ना terbutaline दूंगी ना मैं उसको दूंगी nifedipine. वही loading dose दे दो बस.
मैम गाइडलाइन में सैल्को मैम
गाइडलाइन क्या कहती है?
मैम गाइडलाइन में मैग्नीशियम सल्फेट का ऑफर अप टू 29 वीक बताया हुआ है और कंसीडर अप टू 34 वीक फ्रॉम 24 वीक स्टार्ट करके अगर हम करें तो.
दोबारा बोलिएगा प्लीज.
मैम जैसे आपने यहाँ बताया कि 24 वीक से 32 वीक तक हम मैग्नीशियम सल्फेट ऑफर करें, हम सिंपल ये बता दें एग्जाम में, या हम इस तरह से बताएं कि वी विल ऑफर मैग्नीशियम सल्फेट फ्रॉम 24 वीक अप टू 29 वीक एंड देन वी विल कंसीडर फ्रॉम 29 वीक अप टू 34 वीक, क्योंकि गाइडलाइन में ऐसे लिखा हुआ है।
So मैं तुम्हें एक सिंपल बात बताती हूँ, and you look at the slide on the screen. Now जो इसमें आप late preterm birth और very preterm birth को देखो. So basically 28 weeks to 37 weeks आपकी जो है ये इस सब इन दोनों को देखो, एक्सट्रीम को छोड़ दो. पाकिस्तान के अंदर ये कंसेंसस नहीं है कि स्टिल बर्थ आप कब कहते हैं या आप प्रीमेच्योर बर्थ कब कहते हैं. So basically in Pakistan effectively premature birth is taken from 28 weeks onwards. उससे पहले ये जिसको एक्सट्रीम प्रीटर्म बर्थ कह रहे हैं, हम तो इसको काउंट ही नहीं करते प्रीटर्म बर्थ के अंदर. हम तो प्रीटर्म बर्थ काउंट करते हैं 28 वीक्स ऑनवर्ड्स. So 28 weeks onwards, any baby who's delivering preterm before 24 weeks, you are going to give magnesium sulfate. Simple जवाब. अब आगे तुम्हारे एक्सट्रीम प्रीटर्म बर्थ. एक्सट्रीम प्रीटर्म बर्थ में भी magnesium sulfate दे सकते हैं, but the mortality rate of extreme preterm birth versus abortion in Pakistan is extremely high. तो अगर तुम इसको कन्वर्ट करो तो ये जो प्रीटर्म वेरी प्रीटर्म बर्थ है ये बन रहे हैं 900 ग्राम एंड अबव, और जो एक्सट्रीम प्रीटर्म बर्थ है उससे नीचे वाले हैं. तो हमारे मुल्क में 900 ग्राम से कम तो मेरे ख्याल में रेयर कोई है जो बच्चा बचता. अगर तुम इस तरह से देखो तो तुम्हें बात सारी बड़ी आसान हो जाएगी. फर्स्ट 5 स्लाइड दिखा रहे हैं, ठीक है. तो तुमने अपने आप को फोकस करना है ये मॉडरेट टू लेट और वेरी प्रीटर्म. हमारा इशू तो 28 हफ्ते पे शुरू होता है, उससे पहले तो हमारा इशू शुरू ही नहीं होता. ये जो इम्पोर्टेंट बात इधर मैंने बताई थी कि 30% इफेक्टिवली यूज प्रीटर्म बर्थ है, ये बात मेरी ना भूलना. एंड आई थिंक दिस इज वेरी इंपॉर्टेंट इन रिड्यूसिंग द इंसिडेंस ऑफ प्रीमेच्योरिटी. हमारे 3 मिनट रह गए, सो इज देयर एनी क्वेश्चन?
मैडम डोज बता दें मैग्नीशियम सल्फेट की डोज.
मैग्नीशियम सल्फेट की डोज है मैडम 4 ग्राम.
डोज बता दें प्लीज.
4 grams to be given as an infusion in 30 minutes, followed by 1 gram per hour for 24 hours. मैं ये निकाल के दिखा दूं. ठीक है, 4 gram over 30 minutes, then 1 gram per hour for 24 hours. तो जी सर आगे. वो आज चलती है तो 2 मिनट और है. अच्छा मैं समझ गई सर आने वाले. जी एनी अदर क्वेश्चन? एनीथिंग एल्स गर्ल्स? सो नेक्स्ट क्लास जो है वो हमारी कोविड की होगी, और मैंने आपको ये बताना है कि मैं कोर्स के लिए आपके लिए क्या कर सकती हूँ. वो करके I will tell the group and they will share it with you on the group, and then we can have a small course online on how to do talks. ठीक है? Okay dears, bye bye.
Thank you, ma'am. End कर दें meeting.